Welcome. My name is Christophe Sass. I'm a sports physician of Belgium and I will speak about PRP and muscle injuries. I want to focus today on muscle injuries because they are very typical for sports and certainly for football medicine. But the problem is that there are almost no articles available of any value in the literature. There are only two exceptions: a quite recently published level 2 study which was published at the end of 2014 and compared a rehabilitation in a single therapy towards the rehabilitation in combination with PRP. This study concluded that the combination of rehab and PRP showed a significant better and faster healing process. And there is an older study that compared ACP and a combination of actovegin and Tronmeal in hamstring injuries. That study showed a significant faster return to play in the ACP group. But why is there a lack of level 1 and level 2 evidence? There are two main reasons. First of all, there is no such thing as a standard PRP. You see here the different types of PRP. On the other hand, there is no such thing as a standard protocol. Different studies use different injection protocols. Some used 1 injection, others 2, 3, or even 4 injections. Also in sports medicine, there is a lack of evidence due to a difficult setup for level 1 and level 2 studies. On one hand, we have the amateur player who present at a different moment after the injury. We have a wide range of rehab programs and a wide range of physical pre-injury level. The different profession of these players can affect the healing process in a different way. On the other hand, we have the top level players who want to be as fast as possible back into the pitch, because a faster return to play means a financial benefit as well for the player as for the club. So it's very difficult to convince these players and to convince the club to be in the control group. So in sports medicine we need specific studies, because in general medicine we are looking for a better final outcome and a good cost effectiveness. In sports medicine we are also happy with a faster healing, even if the outcome is the same. A good cost effectiveness is less important because there is enough money in football, and we are also looking for a little improvement in function and a little bit less pain. What do we know at this point in muscle injuries? We know that there is certainly a rationale for the use of PRP. We know that there are proven benefits in vitro studies. We know that pure or leukocyte poor PRP is probably better than leukocyte rich PRP by avoiding the catabolic effect of leukocytes. We know that a moderate platelet concentration should do the job, and that a higher platelet concentration can be even detrimental. We know that there is a tendency towards multiple injections in osteoarthritis, and we know that PRP is a very safe treatment, that there are almost no adverse events, and if they occur, they are minor. Professor Jan Ekstrand from Sweden, from the UEFA Champions League injury study, showed us the typical location of muscle injuries in top-level football players. The most frequently injured muscle is the hamstring, more in particularly biceps femoris, followed by the adductor longus and the quadriceps. Less frequently injured is the calf. What we also know is that most injuries occur at the myotendinous junction. We have two different types of muscle injuries. On one hand, we have the functional muscle injury, on the other hand, the structural one. In the functional muscle injury, we have on imaging no visible lesion or only edema. It can be overexertion related, or it can be neuromuscular muscle related. In that case, it's spine or muscle related. These types are the type 1 and type 2 in the Munich classification. On the other hand, we have the structural ones. On imaging, there is always a lesion visible. It can be a minor or moderate partial tear, or even a total tear or a tendinous avulsion. Now I want to share my personal experiences in the treatment of muscle injuries with PRP with you. In functional lesions, there is no need for PRP. In structural lesions, we can use it. The only pitfall are the minor muscle injuries. These small lesions can result in retractile scar tissue after treatment with PRP due to TGF-beta1, which is a profibrotic enzyme. A possible solution is losartan, a TGF-beta1 antagonist who could reduce fibrosis. Unfortunately, I don't have experience with it, and there is no proven evidence in the literature yet. For moderate and complete tears, PRP gives great results. And if there are tendinous avulsions, you can choose for surgery, but if you go for a conservative approach, PRP is a perfect indication. At least, and at last, it works perfect for me. Welcome back in the clinical examination room. We are here now for the clinical approach of the muscle injuries treatment. This player got injured last weekend during a game. He felt a sudden pain in the right groin when he kicked the ball. I just finished the history taking, and I started with the testing of the range of motion of the healthy side and the strength tests of the healthy side. I will show you now the assessment, the complete assessment of the injured leg. So we will start by testing the range of motion. At a given point we see the difference between the injured and the uninjured side. Here he feels pain. Afterwards we're gonna test the isometric strength, and we ask him to push, and he will feel slight pain now in the right groin. Afterwards we're gonna check the concentric strength, and then again he feels pain, and now I will ask him to push some more, and I will test the eccentric strength, and then he will feel a sudden pain. I usually end with a palpation because I don't want to be the whole side harmful and painful because of the palpation when I do the functional assessment. But we palpate, we start at the beginning of the adductor longus and we palpate to the proximal side of the adductor longus. Until now we feel a normal tonus of this muscle, but if we come to the myotendinous junction of this injured athlete, we notice that there is a hypertonus in the myotendinous junction, which is also painful by palpation. This zone we're gonna mark because we have special attention for it during performance of the ultrasound. After the clinical examination, we do an ultrasound to visualize the lesion on a correct way. We can also perform an MRI, but here in my practice we can immediately perform an ultrasound. And then we can see on the screen the normal muscle, and when we go closer to the myotendinous junction, we can see that there is a strain. So now we know that this player suffers from a strain of the adductor longus. It's a moderate tear, so it's a perfect indication for PRP, and we're going to start the ACP procedure now. So I have explained to the patient the whole procedure, and we are going to start to take the blood sample. So you can see it's a very easy procedure. We just take 50 milliliters of blood and we put it during 5 minutes in the centrifuge at 1500 rounds a minute. Close the machine and we put on start. So now the ACP sample is ready. We're going to take it out of the centrifuge after the 5 minutes plus the deceleration time. This is what we get. We have the red blood cells below and the sample that we need is above, and we're going to take it out by this closed system. I usually take it here fixed so that it's easy to push down and to aspirate the yellow part. Mostly it's around 3 milliliters. If you have aspirated that sample, fix it like this, keep it like this, and you turn it loose like this. Then you have the sample, and you could put the syringe on it. Afterwards we can prepare the ultrasound for an ultrasound guidance injection in the muscle strain. So now we are ready for the injection. We do that under ultrasound guidance. I usually use an intramuscular needle, but for superficial muscles like the adductor longus, you can also use a less long 20 gauge needle. So we're gonna disinfect again. We're gonna look for the lesion again. You have a clear view over there. The adductor longus muscle. Gonna introduce the needle. We see it on the image over there in the middle of the image. We go for the lesion and we gonna inject under ultrasound guidance. You see it here. We just fill out the gap. We don't exaggerate. That's not necessary. After 1 week we will make a new ultrasound and we can repeat the ACP procedure if necessary. So we just finished the first ACP treatment in our patient. I just want to add this remark. If MRI was used as a diagnosis tool, we have to make also an ultrasound in the pre-treatment phase. Why? First of all, because we need it as a reference, and second, because we need to identify the injection spot. Concerning rehab and follow-up, usually after the first ACP treatment I give the player 1 day off. The second day he starts rehab as planned. Every day there is a functional assessment, and after 1 week we make an ultrasound again to see how the evolution is of the strain. If necessary, we make a new ACP treatment, and again the player will have 1 day off after the injection. Usually we plan the injection after the rehab session, in that way we only lose 1 instead of 2 days. The second day after the injection, the player will start again with rehab as planned as usual. In conclusion, I just can say ACP is a great treatment option if it's used in the right indication.